There we are. Lauren Freeman is a professor of philosophy at the University of Louisville and the director of the Master's in Applied Philosophy there. She conducts impact-driven, interdisciplinary research that aims to understand how members of marginalized groups are oppressed in both obvious and subtle ways within the context of science, medicine, health, and healthcare. She's known for pushing bioethical and medical research to include patient groups who have traditionally been excluded from discussions, specifically patients who are marginalized on the basis of sex, gender, race, body size, disability. Her research has been featured in Nature, chosen as a feature article in prestigious health sciences, philosophy, and policy journals, and has gotten media attention. Dr. Freeman has also been invited to lecture on health equity and health justice at medical and nursing schools across North America. She's given workshops to healthcare, legal, healthcare risk management, and medical audit organizations across the US, Canada, and the United Kingdom on how to implement more just, compassionate, and equitable healthcare to members of marginalized groups. Dr. Heather Stewart is an assistant professor of philosophy at Oklahoma State University. Her research and teaching take an intersectional feminist approach to analyses of medicine, healthcare, digital technologies, and artificial intelligence, with a particular focus on how power, oppression, and privilege shape individual and collective engagement with these institutions and technologies. Her work also aims to illuminate strategies for mitigating the myriad harms and injustices that occur for marginalized people and communities in these contexts. Heather has published peer-reviewed research articles in top journals, including the Kennedy Institute of Ethics Journal, the Feminist Philosophy Quarterly, and Perspectives on Psychological Science, among others. Heather's also contributed several chapters to edited books and volumes, regularly contributes to public-facing philosophy, and is a co-editor of a special issue with Ariana Falvo of the APA newsletter on feminism and philosophy on first-generation and low-income philosophy. Her first book, which you will hear about today, Microaggressions in Medicine, co-authored with Dr. Lauren Freeman, was published by Oxford University Press in February of this year. She was previously awarded an OSU Humanities Fellowship to work on interdisciplinary research on issues in digital humanities and AI, and is currently part of an SSHRC Insight Grant funded research team focused on institutional distrust and injustice, focused on LGBTQ+ people's distrust in healthcare. Her research has also been recognized with several prestigious awards and accolades, including the Canadian Governor General's Gold Medal for Academic and Research Excellence and the Oklahoma State University Early Career Faculty Award for Scholarly Excellence. Heather has a keen passion for making philosophy, academia, and the world around us a more just, fair, and equitable place. And she brings these commitments to her teaching, advising, and mentoring of undergraduate and graduate students. In particular, Heather values the important work she has the privilege of doing with queer students and first-generation and low-income students. And I am very excited to hear about this, so please take it away, Dr. Freeman and Dr. Stewart.
Thank you so much. Let me just share our screen again, and we can get started. Thank you so much for that generous introduction. And it's such an honor for both Heather and I to be here with all of you. We're really thrilled at the opportunity to share our recent work and our book, and of course, to hear from you. Thanks to Stephen for this unbelievable invitation, and to Emily for all of the logistics. So just in terms of what's going to happen, Heather and I are going to go back and forth and present different sections of the talk. And then hopefully we'll have at least around 10 or 15 minutes at the end for a Q&A. Okay, this is not, 1 second, not advancing. All right, like that. I acknowledge the difficulty of doing a land acknowledgement statement in online venues, given that we're all on different lands. So I will do it from the perspective of where I'm standing right now. The land I occupy at least, now called Kentucky, is the homeland of more than 20 indigenous tribes, including peoples known as the Shawnee, the Cherokee, and the Osage. Indigenous peoples have lived on the land that's now called Louisville for over 12,000 years. And I'd like us to honor the land itself and acknowledge the presence and influence of Indigenous peoples of the past and the over 30,000 Indigenous peoples living in Kentucky today. This kind of acknowledgement, of course, doesn't take the place of an effective communication and relationship with the land or with Indigenous peoples, but it does serve as a very preliminary first step to honor the land and build community with those who inhabit it with us. And this kind of statement is particularly important given the commitments of this talk, and I think of this lecture series as well, with regards to this talk, Injustice in Healthcare. Since Indigenous peoples are members of marginalized groups, and members of marginalized groups experience the kinds of injustices and many others that we're going to talk about today in healthcare and beyond. So let's just take a moment to recognize the enduring presence of Indigenous peoples in this area and in the area on the land on which you stand as well. Just quickly, the learning objectives for the talk. So after this hour, hopefully everybody in attendance will understand what microaggressions are, identify the immediate and enduring harms that microaggressions can cause for members of marginalized groups, and can discuss, and we're going to discuss together, practical tips for reducing microaggressions and increasing health equity in clinical encounters. So in terms of the structure of how we're going to do that, and we are being wildly ambitious, but I have high hopes that we will achieve the goal. First, a quick caveat. Then, like good philosophers, we're going to define what microaggressions are, especially given that this is a term that really arose within academic context, but has now really overtaken popular discourse. And of course, when that happens, there's often an overuse and a misuse of the term. So we want to be very clear about what microaggressions are in the more technical sense that we're going to be using them. We're going to go over a couple of case studies and analyze those case studies in line with the analysis that we push in our book, which is to really focus on the harms of microaggressions for those who experience them. We're going to generalize some common mistakes that happen based on the analyses that we do. And we're going to conclude by really focusing on the longest chapter of the book, which is chapter 7, that was written explicitly for healthcare professionals as a kind of how-to guide, how to avoid committing microaggressions in your individual practices, in your offices, in your institutions. And of course, that will be a very truncated discussion of a very long chapter. And then, of course, we'll end with a Q&A. So very quickly, a couple of caveats. So first, we just want to be clear about our own social position and identity. So Heather and I are both cisgender white women, and our research and advocacy focuses on oppression in medicine and healthcare. It's really important to note that we don't personally have all of the lived experiences of the members of the communities that we're going to be talking about today. And for a long time, we sort of struggled with our own social positions with regards to the subject matter of our research. And, we sort of thought, this isn't really, in lots of ways, not really our own personal fight. Should we even be taking this on? And we've really done a 180 and come to the following conclusion that we'd like to share. So it's pretty obvious that now, but not just now, really historically always, the lives of racial and gender minorities have been and continue to be under attack. And the people who are members of these groups are really tired of fighting alone for their basic human rights, are tired of standing up alone for themselves, and are really tired of having to take on the burden of educating others about and all of the emotional labor that takes on. So we need advocates and allies to be doing some of this heavy lifting social justice and health justice work. So we're no longer worried about why we're doing this or whether we should be doing this, but it really is important for us to underscore that at the center of our work is storytelling and personal testimonies to elevate the lived experiences of members of the groups that we will be discussing. And so we're always careful never to speak for members of marginalized groups, but rather always to amplify their voices and testimonies and stories in ways, we have a lot of power and privilege to be able to talk at lecture series like this. And so we want to just be very mindful of how we're using our social position. Very quickly, we sort of want to start with the conclusion, which is, although we're going to be talking about a lot of case studies where healthcare professionals commit harm toward patients, the conclusion that we want to reach is not that we should be blaming individual healthcare professionals or that this is just a matter of a few bad apples and we need to get rid of them. We want to focus or just emphasize at the beginning that we're really focused on the structural upstream issues that lead to the downstream downstream symptoms which manifest as microaggressions. So we obviously have the highest respect for healthcare professionals. Very quickly, the language that we're going to be using is really important, and it's importantly guided by members of the communities that we're going to be talking about. So in case any of the language seems odd or pejorative or out of place, please know that it was very intentionally chosen in a way that honors and is guided by members of the communities that we're going to be speaking about. And finally, feeling uncomfortable. So the content of this presentation might be entirely new to you, and it might make you feel uncomfortable with yourself, with your coworkers, with your institution. And so if that is you, we just want to start by offering a special thanks for showing up, because that's sometimes not easy. And we really do want everybody to feel as comfortable as possible to ask any manner of questions in the Q&A. So now we can really get started, and I'll pass it over to Heather.
Thanks. Okay, so to get started, what exactly are microaggressions? So in the academic literature on microaggressions are generally understood to be actions, gestures or body language, or even features of physical or material spaces or environments that subtly and often unintentionally harm members of marginalized groups. They're rooted in either implicit or explicit prejudice and or racial, ethnic, gender, sexuality, religious, disability, or other kinds of stereotypes and biases. And microaggressions are characteristically frequent and reoccurring in the lives of marginalized people, and as a result, they lead to cumulative harm that compounds over time. So let's consider an example of microaggressions. So there are some common examples of microaggressions in the image on the left, which occur on the basis of perceived race or ethnicity, but we're going to consider a different kind of example here on the right. So in this example, a 15-year-old is addressing their older sibling. They say, "I have something to tell you. I think I'm asexual." Their older sibling then responds, "Oh, don't be silly. It's just that you've not been with the right person. Don't worry, you'll get over it. It's natural to not be attracted to anyone just yet." So thinking about this example, why is this exchange a microaggression? So you might have noticed, right, the older sibling doesn't seem to want to cause any harm to their younger sibling. Indeed, they're likely trying to be sort of comforting or reassuring to their younger sibling. However, the effect of their words is likely different. The effect of their words sends the message that the younger sibling is mistaken or confused about what they take to be their asexual identity. And moreover, it implies that asexuality itself is not serious or real. So the comment, even while possibly and likely well-intentioned, dismisses the younger sibling, as well as erases and undermines a claim that the younger sibling is making about their asexual experience or possible identity. So microaggressions can be interpersonal. They can occur between agents, like the example we just gave of the older sibling addressing their younger sibling. They can also be environmental, so found in features of built environments or physical spaces, and not necessarily the result of any single identifiable agent or directed at any particular person. Microaggressions cause harm to those on the receiving end. So on our account, microaggressions can harm one as a knower, and we call these epistemic microaggressions. On the basis of their proper emotions, or what we call emotional microaggressions, or on the basis of some feature of their identity, which we call self-identity microaggressions. Microaggressions target people who are members of marginalized groups, and these occur for people who are members of marginalized groups, both in general and for our purposes in medical context. So this includes women, queer people, trans and non-binary people, disabled people, Black people, and people who sit at the intersection of multiple of these identities.
Okay, so now that we have our basic definitions in place, and I hope we all understand what microaggressions are, we're going to go over two case studies. And the first one is the case of Tressie McMillan Cottom, and she is a self-described fat Black woman. And just a content warning here for discussions of gendered racial violence and miscarriage. So probably most people here have heard of Cottom. She's in the last several years become quite a well-known public intellectual. And the case that we're going to be talking about here is a chapter in her book of collected essays called Thick. And so despite her social standing and countless intellectual and academic achievements as a self-described fat Black woman, and at the time she was pregnant, Cottom knew that her identity would make her face an array of discriminations. And so for this reason, she carefully chose her physicians, or so she thought. When she's a MacArthur Genius Award winner, so she's quite a well achieved person. When she was 4 months pregnant, she was bleeding and experiencing acute pain. And she and her then husband knew that something was really the matter. So they immediately went to their doctor's office. And instead of being seen immediately, they took this to be a clear emergency. She was just told to sit and wait in the waiting room, just like everybody else. And so she was actually bleeding everywhere and asked several times if she could get some privacy. When she was finally saw her doctor, he just quickly looked at her and said that she was probably just too fat, and that for, quote, women like her, spotting at this stage of pregnancy was very normal or typical. And so she was sent home. Later that night, her pain escalated, and the on-call nurse assured her over the phone that because the pain was in her lower back, was in her bowel and not in her lower back, that it was probably just constipation and she should try and go to the bathroom, which she did for 3 days with no luck. And so she finally took herself to the emergency department, insisted that she get an ultrasound. She had to ask many times. And on that ultrasound, it showed not just a fetus in her uterus, but 2 large tumors. Upon seeing this, the nurse told her, you really should have said something to us. Soon thereafter, Cottom went into early labor. She ended up giving birth to her daughter very prematurely. Her daughter died shortly after she was born. And after that happened, another nurse told her, just so you know, there was nothing we could have done since you never told us you were in labor. So importantly, and we just want to start with this, that the result of this case, the result of the microaggressions is nothing micro, and we will discuss those in a moment. But our analysis really focuses on the racialized and gendered epistemic microaggressions that combine in ways that are unique to Black women. And in the book, we call this the misogynoir of microaggressions. Cottom knew that there was something wrong. She tried to convey this knowledge to her healthcare team, yet she continued to be viewed as lacking credibility with regards to the knowledge of her body. And this has been called the credibility gap. The result, of course, is a variety of racialized and gendered epistemic microaggressions that she experienced in her capacity as a knower. As a pregnant Black woman who was bleeding and in pain, she was told that her bleeding was attributed to her fatness. When the pain in her bowel was dismissed as being a consequence of something bad that she'd eaten, bad there has racist undertones about the kinds of food that Black people might eat. And after the death of her newborn daughter, she was blamed for not having spoken up sooner. So the implication there is that the death was in part her fault and or could have been prevented had she spoken up sooner. So Cottom here is powerless relative to her healthcare professionals. Her knowledge of her body is ignored, and the healthcare professionals assumed that at all points of this story that they knew better. On account of her race, gender, and body size, what we argue is that Cottom suffered the epistemic harm of not being recognized as a credible knower, the practical harms of serious physical pain, the death of her daughter, and the enduring trauma of the whole tragedy. These consequences, to be clear, are macro and tragic and likely could have been avoided had she been listened to earlier, or if not avoided, certainly this case could have ended very differently in terms of her own emotional and identity and epistemic states of being. So that was the first case.
Okay, the second case we're going to consider is the case of Roxanne Gay, who is a self-described fat, Black, and queer woman. So in Roxanne Gay's book, Hunger, she describes the following about her sort of experiences in healthcare spaces. So she writes, when a nurse asks me to step on the scale, I often decline, tell her that I know how much I weigh. I tell her I'm happy to share that number with her. Because when I do get on the scale, few nurses can hide their disdain or their disgust as my weight appears on the digital readout. Or they look at me with pity, which is almost worse because my body is simply my body, not something that demands pity. She continues, there's the humiliation of simply being in the doctor's office, which is all too often ill-equipped for the obese body, despite all public hysteria about obesity and health. Many scales cannot weigh people over 350 pounds. Blood pressure cuffs are always too small, as are the threadbare hospital gowns. It's also difficult to climb onto the exam table. It's difficult to lie back, to make myself vulnerable, and to be splayed wide open. So Gay's case and her sort of description of it provide examples both of interpersonal and environmental microaggressions. So starting first with the interpersonal dimension of microaggressions that she experiences what we call self-identity microaggressions that fat patients experience on account of being fat. And in Gay's case, these are compounded by her also being a Black and queer woman. So you might have noticed that the nurse didn't necessarily say anything explicit to signal disdain or disgust at Gay's weight, but Gay still sort of understood or perceived the messages being sent by the nurse's grimaces and other facial expressions and body language. So a nurse might sort of defend themselves here and say, well, it wasn't intentional, right? These are just sort of automatic bodily sort of responses. But the harm to Gay is nevertheless done. And this is true in general, that the harm of microaggressions occurs regardless of whether the actions are intentional or even sort of conscious to us. In addition to the interpersonal microaggressions that Gay describes, there's also environmental microaggressions. So recall, microaggressions needn't be sort of verbal. They can also be institutional or features of the physical space or environment. So for example, Gay describes clinical spaces with furniture that can't contain or fit her body, hospital gowns that don't adequately sort of cover her body, blood pressure cuffs that don't fit her body. So in this kind of example, the physical space literally cannot accommodate or contain her or fat patients. And it's worth noting that she said in her testimony, right, often there's not the necessary equipment to weigh patients over 350 pounds. What often happens in these cases is that those patients are sent elsewhere to be weighed, namely to places like dumps and zoos. And you can think about what the sort of cumulative effect of these kinds of messages are, right? They say, you don't belong here, you don't fit here, this space isn't for people with bodies like yours. So though we just considered 2 case studies, there are also a plethora of other kinds of microaggressions that occur in medical contexts. So we're going to just briefly flag a few of those. So other common microaggressions include women and women of color not being believed about their claims to being in pain. Women assumed to be overreacting in response to their pain or symptoms. Physically disabled people being treated or spoken to as if they're cognitively disabled, and similarly, elderly patients being treated as if they're cognitively impaired based on their age, so maybe being spoken to sort of slowly or something like that. Children not being believed about their claims of their symptoms, and Black people being treated as incompetent knowers about their bodies and not believed about claims to pain. And finally, bisexual and non-binary people's experiences being treated as unreal or invisible. So these are all reflective of combinations of epistemic microaggressions pertaining to people's status as knowers, and also self-identity microaggressions pertaining to aspects of their identity and lived experience.
So now we want to just sort of focus on the harms of microaggressions. And to be clear, and there's so much to be said about this, and we spend a lot of time in the book sort of engaging with the literature on microaggressions, but there's an extent to which even the term microaggression could be considered a bit of a misnomer, because microaggressions are only micro from the perspective of the one committing them. From the perspective of patients, they're not micro at all, especially given the cumulative impact of microaggressions. Microaggressions result in both immediate and long-term harms. And so, for example, the failure to treat patients as dignified human beings worthy of respect. Microaggressions undermine patients' sense of self by failing to recognize and respect the significance of how our bodies and/or our embodiment impact our sense of selves as people. There's a failure to recognize the credibility of certain groups of knowers. And all of this worsens the stigma associated with and further devalues already marginalized people. It's really important to pause for a second and note, and this is something that sort of really, I think, intentionally misunderstood by critics of microaggressions. So as we've said a number of times, microaggressions are not like that thing that happened to you that one time. If you're a member of a marginalized group, microaggressions likely happen on a daily or weekly basis. And so there's a sense in which that one microaggression might not seem like something big or worth paying attention to. And it's easy to say that if you're not on the receiving end. But when you're on the receiving end, that one, being misgendered, if you're a trans or non-binary person, that might be the 15th time you were misgendered, in the last 2 days. And so when there is a large reaction or response, it might not be just in response to that one incident, but rather sort of the cumulative effect. So we're in a Zoom call with 187 people, and I'm willing to bet that if there's one claim that we would all agree on, and there might just be one, and it might just be this one, it is that trust is the cornerstone of high-quality medical care. Distrust from experiencing microaggressions can contribute to doubts about the efficacy of healthcare. And when you read extended versions of testimonies, you really see this coming out. You also see this is there's so much data to show that people who experience microaggressions often delay medical treatment or forego medical treatment altogether. Microaggressions, due to the mistrust or distrust that accompanies it, can result in missed or incorrect diagnoses, prolonged illness, and sometimes even death. All of these factors, of course, deepen the physical and emotional harms that accompany illness, as well as the harms pertaining to one's self-identity. So one of the main arguments in our book is that when one's health, well-being, and in many cases, when one's very life is at stake, it's imperative to trust and to have a positive relationship with those in charge of your treatment and care. And experiencing microaggressions in medical contexts can undermine this trust in healthcare professionals and institutions. So what we aim to do in the book and here today is to bring attention to microaggressions that arise in medical contexts in order to work to eliminate them, or to diminish them as much as possible. Most realistically, we won't eliminate them, but diminishing them as much as possible is sort of the best we can do. So Heather's going to now talk about some common mistakes before we conclude with some practical tips.
Okay, so let's consider some common mistakes that can lead to microaggressions. So one common mistake is the mistake of not taking seriously claims that patients make about their experiences of symptoms or pain or their conditions or facts about their bodies, their identities, or their experiences. This is a common mistake made along gender lines, racial lines, or the intersection of race and gender. Another common mistake is making assumptions about patients based on how they look or how we perceive their identities. Another common mistake is not respecting the sort of diversity of body size and making the incorrect assumption that fat always equals unhealthy or inactive or something like that. And related to that, the sort of mistake in physical clinical environments of not having the appropriate tools or materials or resources to accommodate certain patients, including patients with larger bodies. So some important reminders. So Lauren mentioned this at the outset, but many of the problems that we've discussed today are structural and systemic, right? They're not necessarily the fault of any one particular individual. They're the result of a combination of things, including implicit biases, lack of or inadequate training around some of these issues, from the fact that we all exist in a racist, homophobic, transphobic, cisnormative, and fatphobic society. It's also important to keep in mind that microaggressions are most often unintentional and often sort of fly under our conscious radar. They're the result of damaged healthcare systems and damaged societies in which they exist. They often result due to various kinds of pressures and constraints that are on healthcare providers, including, for example, time constraints, limited resources, a sort of emphasis on efficiency, perhaps above other things we might value in medical context. And they have been exacerbated by and since the COVID-19 pandemic, which exacerbated some of those limitations on time, resources, and so on. So, of course, we're not going to change all of those background structural and systemic features or conditions that contribute to microaggressions today or alone. And that might lead you to think, well, I'll just throw up my hands, right? There's nothing I can do. But we want to resist that sort of fatalism about microaggressions and instead try to highlight some of the things that we can do as individuals. So in the hopes of changing systems and in the name of justice, we can work to change a number of things. We can work to change what we do as individuals, our individual behaviors, how we talk to patients, our habits. We can try to habituate different ways of talking to and interacting with patients, our actions, and things that occur within the immediate spaces we can control, like our practices, for example. So let's consider, sorry, Lauren.
Oh, go ahead.
Nope, go ahead.
So we're just going to end by, again, trying to summarize in 2 or 3 minutes the longest chapter of our book, which is chapter 7, which again was written for healthcare professionals. And so we're going to just go over some of the practical tips that we've come up with. It is worth noting, though, that we intentionally left this chapter not complete in a sense. So in the book, there are several pages that we leave blank because we really genuinely think that, we've given a list. It's not an exhaustive list of things that people can do, but we really want to build this in collaboration with audiences like you. And so we would love to hear other things that you found worked or didn't work in your own practices. So one thing that we talk about, and we did not invent this concept, but we sort of revitalized it for our purposes, is the idea of micro cues. And micro cues refer to small indications that signal positive affirmation, recognition, or being welcome. So these can include inclusive intake forms, having many options for sex and gender, asking for affirmed names and pronouns, and this is in response to the pervasive, misgendering and dead naming trans and non-binary patients, for everybody to use and display pronouns themselves, especially cisgender people, thereby taking the burden off of only trans and non-binary people for displaying pronouns, having gender-inclusive restrooms, and displaying diverse bodies, sexualities, and families in the medical literature that you choose to display in your clinics, in the visual images in your clinics, and even down to the magazines in your waiting rooms. All of these things can signal to patients that you are an inclusive practice. So micro cues can help to establish and build trust. They can help to establish and build open and honest communication, which of course results and can result in better adherence to medical treatment plans and also to your patients coming back. But this tip comes with a huge caveat that micro cues only work if they are genuine and not performative. In other words, if all of the staff and all of your colleagues have the adequate training to back up what the micro cues are signaling. But in the absence of that, micro cues, if you, have a pride flag and, misgender people and don't call people by their affirmed names and pronouns, it can actually backfire in pretty massive ways. Second, representation really matters. And so we talk about hiring members of marginalized groups in all levels of your practice, having diverse representation in all levels of decision-making. Patients really notice this, and they notice this because it can trickle down and help to improve the climate in clinics, the practices that you have, the policies that you follow. And doing this really shows patients, instead of just like having a pride flag or having translators, it shows patients that you are an inclusive, welcoming practice committed to high quality, equitable, and inclusive care for all patients.
Okay, so another practical tip involves trying to increase awareness of microaggressions and their harms, both for yourself and for those around you. So continuing to educate yourself about the role of things like implicit and explicit bias in medical encounters, which contribute to microaggressions, becoming more consciously aware of microaggressions and other possibly discriminatory behaviors, understanding the very real and enduring harms of microaggressions for marginalized patients, and working to change your actions and reactions when microaggressions occur or when microaggressions have been pointed out to you. And of course, this is difficult, right? This is a commitment and it sort of takes time. We also in the book discuss medical humility. So this involves a number of things, including believing someone when they tell you that they have been harmed by something that has been said or done or occurs in a clinic, being receptive to correction and critique when someone says that they've been microaggressed or harmed, or that someone has observed a microaggression, perhaps that you have committed, expressing humility in the face of that, apologizing and doing so from a place of sincerity, learning from your mistake, and of course, trying not to repeat that mistake, right? Trying to do better next time. And finally, a huge part of this involves trying to educate yourself and your colleagues, again, maybe about lived experiences that maybe you or those around you don't have. So we've highlighted some really helpful text here, and there's a longer list of these provided at the end of our book. But we have two texts from Zina Sharman here about the experiences of LGBTQ+ patients, a book about kind of the lived experience, the what it's like of being non-binary from Alok, and two books from Aubrey Gordon about experiences of being fat and sort of myths and assumptions and stereotypes about fatness and fat people. Okay, so hopefully we have given you the impression that minimizing microaggressions is important as a step toward increasing health equity. So microaggressions in medical contexts, we've argued in the book and here, cause real and enduring harm for patients who are already vulnerable. And they can further degrade trust or impede clinical communication, which of course can result in things like delayed or avoided care, misdiagnoses, and so on. And the combination of these things can exacerbate existing health disparities that are already experienced by marginalized groups. So we think it's important to recognize, avoid, and try to neutralize the harmful impacts of microaggressions, and that doing so is a matter of health justice and health equity. And that environments with fewer microaggressions are environments which are more conducive to the trust and communication that are so essential for the delivery of high quality care, which we believe all patients deserve.
So just in wrapping up, we have here in this micro lettering on the slide about microaggressions, some further articles that we've written about microaggressions, and of course, our book. And in case you are interested in reading more, we'd like to share with you a 30% discount code that is the AAFLYG6 that can be used at the OUP website. So it makes the book pretty affordable if you are interested. And we would just like to conclude by thanking everybody. We're really grateful that you took the time out of your busy hours, lunch hour, and days to come talk to us. And we're really excited to engage in a Q&A. And so that will be moderated by Stephen. In the meantime, if you were late coming in and didn't have a chance to register for the CME, if you scan that QR code in the top left-hand corner, you can access the document that you need to sign into or put your name on to get CME. So that's really important if you'd like to do that. And I guess we can go to the questions.
Yes, thank you so much. The best way to do this would be to put your questions in the Q&A, and I will try to give as many of these as possible. A couple of questions, both about how do you determine whether something is a microaggression or not? For example, An anonymous attendee asks, it seems like the experiences of Dr. Cottom were just explicit acts of racism. Why call them microaggressions as opposed to just flat out acts of racism? Did Dr. Cottom experience these acts as microaggressions, or is this part of the analysis that you give? So how does that how do microaggressions sit in relation to literature on racism or other acts of discrimination?
Heather, do you want to take that or shall I?
You can start and then I can jump in.
Yeah, so that's a really big question. What are the criteria that are used in order to determine whether or not a microaggression happened? And I think you'll get very different answers depending on who you talk to and depending on what theory of microaggressions you're guided by. So the approach that we like to take is that this is a contextual matter. So it's not as though we can say like all instances of the following act are all microaggressions in any kind of context in which they happen. We are guided by standpoint theory, which is the idea that members of marginalized groups have a particular kind of socially located knowledge and experience that is better than people who aren't located in those social positions and don't experience those kinds of harms. So, so with regards to the Cottom question and case, I mean, I think that there is a sense in which the way that we sort of laid out the case in 1.5 minutes, where we sort of had all of these things like very closely together, in a particular way that we really wanted to guide the case. I think that when it's laid out like that, you might, as you did, sort of conclude like, how can anybody call that micro, right? That those are just explicit racist comments and remarks. But when you read the way that she talks about it, and again, this is speculative. So, we never asked her like, are these microaggressions? But the way that she develops the case and talks about it, it's sort of within a much larger context where these comments are, she's happening over many weeks and months, and so they are sort of like interspersed in other, in sort of a full life, where it's not as though like every single thing that comes out of everybody's mouth is, could be perceived as a racist comment. So the way that and maybe our sort of summary of this didn't do justice to the subtlety of a lot of these things, but a lot of these comments were just sort of like side remarks that didn't necessarily weren't followed up by all sorts of claims about Black women, and so there might be a sense in which the way that we sort of set up this case in a very condensed way sort of maybe overemphasized these components. So I do urge you to read her account and sort of see how she sets up this problem, which is emphasizing a lot more of the subtleties that we sort of try and bring out in our longer analysis. So I'm not sure if that answers it. Heather, did you have anything to add to that?
I was just going to jump in, not about Cottom in particular, but about sort of how to make sense of when something is a microaggression as opposed to a sort of explicit act of some kind of discrimination. And Lauren mentioned at the start of the answer that we take this kind of contextual approach in which the very same act might in some particular context look more like an act of explicit discrimination and look more like something like a sort of unintentional microaggression in another. I think this becomes quite clear if you think, for example, about dead naming or misgendering a trans or non-binary person. There are cases where that act looks a lot like very, very much looks like intentional discrimination, right? There could be somebody with ill will who is explicitly transphobic, who very intentionally uses a dead name or misgenders a trans or non-binary person because they just don't believe that trans or non-binary people are real or worthy of respect or whatever it is. And the same act, right, could be done unintentionally by someone who is well-intentioned, who doesn't mean to cause any harm, right? And it seems like there's something importantly different about those two things, right? They're the same act on their face. Somebody's been dead named or misgendered, but in one case, somebody has done so from this position of sort of malice toward trans or non-binary people, right? Maybe with ill intention. And on the other hand, maybe somebody has made a very genuine mistake that they certainly didn't mean to cause any harm or certainly didn't mean any ill will. So sometimes the very same act can have these kind of different appearances based on other contextual factors, right? Including but not limited to the kind of intention and emotional states behind the person doing them.
Oh, Stephen, I think you're muted.
Fiddlesticks. You made a good point about microaggressions only being micro for the sender and not the target. If you could rename the term to better emphasize impact versus intent, I'll just read it directly. What language would you use?
Yeah, so we talk about this all the time, and it's such a difficult question, and this is such a difficult phenomenon, and this is why we find it to be so interesting, because the same act, from the perspective of the person who commits it, like from the perspective of the nurses, right? They might have been trying to be comforting, like they might have been genuinely well-intentioned, and yet this act falls, it just completely misfires when the patient experiences it. And so and I think Stephen, when you were introducing us, I just wanted to say that we have such a debt of gratitude. Stephen read a version of this project when it was like a 3,000 word paper 11 years ago. And I think that we had this conversation about the term microaggression, and we've, for 11 years now been debating like whether or not we should like get rid of the term. And we ultimately decide not to. So we think that there is something meaningful about this term that describes something that is most often not intended to cause harm, often intended to help, and yet so radically misfires. And so that's why we keep the term, and we're not interested in using something different, but we really want to draw out that it is only micro from one perspective. Something that we didn't really get to talk about in this talk, and that comprises sort of the first third of the book, is the fact that the first third of the book completely reorients the concept of microaggressions. Oh, the way that they were introduced originally was precisely from the perspective of the one committing them, which might explain why they're called microaggressions. And so what we do is we want to reorient the concept to focus on the harms that patients experience. So it might be the case, and I appreciate the question, it might be the case that our next project has to precisely rename this thing from the perspective of the person on the receiving end. But then we're sort of forced to confront this problem of like calling them aggressions or whatever they are, massive harms. But that again doesn't do justice to the entirety of what they are, because that they might have just been an eye roll. There might, if we look at a lot of different examples of the environmental microaggressions, those are even more tricky because there isn't a single agent committing an act that is harmful. So although we've had countless hours of discussion and debate about what do we do about this word, this very problematic name, we retain it with sort of a lot of reservation.
If I may just add quickly, I saw that there's another question in the chat, in the thread, whatever, that says, is there such a thing as macroaggressions? And I think that's another thing that the term microaggression does, is really sort of paint that contrast. And this speaks to the first question about like separating microaggressions from very explicit, overt acts of discrimination, right? So there are macroaggressions, right? And they are those kind of very explicit, overt acts of discrimination, harassment, and so on. And some of what our larger project in the book is doing, as Lauren was mentioning, is trying to separate out some of those things that maybe other people have labeled as microaggressions that we think fall more in the category of macroaggressions. So it's just to follow up what Lauren was saying with someone else's point in the chat, that if there are microaggressions, are there macroaggressions?
Two questions addressing issues with children. Could you gave examples about children not being believed about their symptoms. Could you say more about other examples and issues with children, and more about the harms, especially since children are developing, and how the immediate, medium, and long-term harms are specific to children's experiences? And perhaps especially if you have specific advice for a discussion between a pediatric patient and their parent who does not agree with the patient's use of pronouns. perhaps I joined two things that aren't easily joined, but I just threw them together. So
So we do mention children, and this is really something that we don't talk about in the book, and really like a future project. So I can't promise that we have as robust a response to this, but I think it really does speak to an area that is completely underdeveloped. And it's really hard. I mean, especially if you have children, right? You really struggle, they don't want to go to school and they have a stomach ache and you want to believe them, but like also they've had 15 stomach aches and maybe it's real and maybe it isn't. So, our default is we want to trust people. We want to trust people who are members of marginalized groups, and we want to trust people, especially for whom there's a history of not believing them and gaslighting them. And we've spoken to so many healthcare professionals over the years, and we always sort of throw this line like we want to trust patients, and we are not healthcare professionals, and we are not on those front lines, and we've gotten a lot of pushback there. People are like, well, women are hysterical, and like sort of throwing back in our faces all of the stereotypes that we're trying to resist and reject. And so ultimately, what we want to push is, doing the least amount of harm. And doing the least amount of harm generally involves believing people. Typically, when you're engaging with children, you do have some kind of relationship with them. And so hopefully that, will result in, if you trust them and listen to them and make them feel as though they're heard and they can trust you, hopefully that will result in the best kind of care. But I also say this, like having been accused yesterday by my 9-year-old daughter of like not believing her that her stomach hurt. So it is more to be, stay tuned, and we hopefully will have more to say about that in a year or in a couple of months. Heather, did you want to address the how to deal with pronouns and children and parents who don't?
Yeah, I don't want to speak for both of us here. So Lauren, if you want to diverge from what I'm about to say, please do. But given that we are sort of motivated by this commitment to minimize harm to people that are in more vulnerable positions or positions of maybe reduced power relative to those around them, I am inclined to think that in this case, the healthcare provider, in the interest of wanting to have the patient, here being the child's, trust, right, to have a position where the child feels as if they can speak openly and honestly about things like their experience of gender and so on. I would err on the side of deferring to the patient in that case, but I recognize some of the complexities Lauren just mentioned, right, of this creates sort of a tension. Lauren, I don't know if you feel the same way about this. And this, of course, is not meant to be one size fits all guidance, right? But
yeah, I mean, again, it's such a tricky issue, and we see this in schools where, children, want to express their non-binary identity, and that isn't recognized by their parents, and their parents, insist on calling, their child she when the child doesn't identify as a girl. And so again, I mean, I think that, and I'm not a healthcare professional, but sort of guided by, wanting to ensure that patients get the best care, one strategy might be to, ask the parent if the doctor can, speak to the child, by themselves, and try and create a kind of context in which the child can express themselves and maybe engage with that in that discussion if possible, not with the parents who are there. But again, I mean, I feel like this is a little bit out of our domain of expertise with regards to microaggressions. But it's thrilling that there are a lot of questions about children, because that really is something that we didn't get to in the book, and something that we're both really interested in looking at. And I just don't know of anything about microaggressions in medical contexts that children experience. So we're very excited to write that paper. So thank you to the people who asked those questions for sort of making it clear that that's something that people want to talk about and know about and think about more.
then what about a different area? Have you thought about how this can be related to or translated to palliative and end-of-life care regarding demographics like socioeconomics, religion, or ethnicity?
Yeah, so so children and the elderly are two groups that we did not really get to talk about much in the book, and two areas where we really want to expand our work. Again, I know of nothing written about microaggressions and the elderly, and in general, and in particular palliative care. And again, I feel like, on these two ends of life, there are very similar issues with regards to loss of autonomy and having to navigate, interfamilial complexities and relationships between like what parents and children and caregivers want for a patient and what the patient wants, and how to honor and respect a patient when they might not be able to communicate as well. And just sort of like all of the assumptions that go into, I think, a perfect storm for creating microaggressions. So again, I mean, this is sort of a project for the future. But one thing that I've worked on a little bit is just sort of looking at how all sorts of social stigma around elderly patients result in microaggressions. The answer that you're looking for, namely, how do we prevent those from happening? I'm afraid to say will have to be a to be continued. But thank you for making clear that that is something that a paper that needs to be written, that we're very excited to engage with. But these are such fantastic questions. So we're really grateful for pushing us.
Another question, what about institutional systems and teaching that perpetuate microaggressions, like Blacks have higher rates of heart disease as a fact of race, but doesn't, of course, mention the stress of daily microaggressions?
Heather, do you want to?
Yeah, I can just start. Yeah, something that we mentioned in the presentation is that so much of like what creates context in which microaggressions occur are sort of things that are structural and systemic, right? And part of that is how medical education and training is conducted, and maybe the false beliefs or stereotypes or biases that may be perpetuated there or not effectively challenged there. And so certainly problematic assumptions about race that are not backed by empirical scientific data, or about assumptions about fat people, for example, those being perpetuated in medical education and training and not sort of adequately challenged and changed at any point thereafter, is certainly going to be something that exacerbates environments in which microaggressions are likely to occur and to go unchallenged. So certainly we do think the sort of structural and institutional issues are part of the larger thing that needs to be addressed if we want to minimize microaggressions.
Okay, not a question, but an observation. Many people who use drugs, especially highly stigmatized drugs like meth or injectable drugs, or have xylazine wounds, avoid going to the doctor or hide their drug use from the doctor, because then the medical practitioners treat them horribly. Then this lack of medical care causes bad health outcomes, which is then treated as evidence that drug users neglect their own health and therefore don't deserve good health care. And of course, this is a nice descending spiral. Microaggressions are one part of this cycle of making drugs more harmful and medically oppressing people who use drugs. This then interacts with classism and racism. Poor and Black drug users treated worse than white or wealthy drug users. Is there any literature, microaggression literature, or other thoughts about this kind of interaction and perhaps even harm reduction that could be done here?
Yeah, that is a great question, and a really hard one, and one where I think a lot of healthcare professionals who are like right in the middle of this, then this is not speculative, this is based on arguments that we've had with healthcare professionals, just take a radically different position than we do. I will never forget, about 8 or 9 years ago, we were giving a talk about this, and we were talking about this kind of issue, namely, we were talking about the fact that you always have to believe patients, and this doctor who had worked in an area where there was a lot of patients who were drug users, actually got up in the middle of a presentation and started yelling at us and basically telling us that we were crazy for saying that doctors should believe patients, because this person was obviously so scarred from, years and years of having to deal with very difficult patient situations. And his position was, I can't believe patients. I can't believe anything they say. And doctors can't believe patients if we want to actually treat them. And so we just sort of took this as just like this horribly tragic consequence of a failed system. And I think you illustrated that failed system so well by showing sort of this vicious cycle of explaining like why this is a problem. And so, with regards to the specifics of the question, one response, and I don't think this has to do with microaggressions. I think this has to do with sort of just very clear and explicit attitudes about the disease of addiction and the illness, is that we just need better social understanding of what addiction is and how it's not like a personal failing and an issue of personal responsibility and people not taking responsibility for their health, but it is a much larger issue that we as a society have to figure out a much better way of responding to, not placing blame on individuals. Because I think that microaggressions, but I think more realistically, just outright discrimination and harm is happening to people because of sort of the personal agency and personal responsibility false narrative that surrounds a lot of drug use and addiction. Heather, do you want to say anything else to that?
No, I do think it's a really good and important question. And yeah, so just seconding what Lauren just said and thinking about how about how the sorts of background stigma associated and lack of understanding of addiction that Lauren was just referencing really contributes to this situation in which active drug users fear being open with healthcare providers, either about their drug use or just more generally, right? This idea that anytime I go into the clinic, right, it's going to be assumed that I'm going into the clinic because I'm drug seeking or something like that. And that can really, right, just exacerbate both various kinds of medical harms that drug users experience that we would want to try to improve upon. So I appreciate the question quite a bit.
Yeah, and I think it really just gets back to trust. And I think the lack of trust on both sides is what is really fueling that problem. And as you really beautifully, if I could even use that word, sort of illustrated, people who are drug users don't want to go to the doctor because of the very real discrimination and stigma that they're going to face there. And then oftentimes, it cascades into a situation where they are, have to seek medical care, and you sort of can't rebuild those trust avenues. So again, I think this is a much larger systemic issue, and I think microaggressions are sort of a symptom here of a much larger systemic issue problem.
In a request that speaks well to your potential book sales, could you scroll back one so that people can see the code again?
Absolutely.
Multiple requests of that.
If I can, let me, where is that?
Or scroll back too, there we are, yeah. Okay, good. When people were asking me, that's what I told them. So good, I remembered it correctly, but yeah. Some have argued that certain terms take away from or reduce the ability to call out injustice, referring to unconscious bias as opposed to calling out racism, for example. Do you feel that microaggressions work to do a similar thing here? Instead of calling out racism or other forms of discrimination explicitly, things get framed as microaggressions, and therefore it reduces the weight or heaviness of the act since it gets collapsed into this more general term of microaggression.
Yeah, I mean, thank you for that question. I feel like that question is like what motivated the book. And this is sort of in response, and we've written about this. People who are skeptical about microaggressions, they really want to use that line of argument. Like, well, if they're micro, why do we care about them? Why are they important? They're just micro and insignificant. And that is, again, another symptom of this problem with nomenclature. But so what we want to do, and we are sort of giving ourselves a really difficult problem because we do want to retain the term microaggression, but what is motivating our work is to show that microaggressions are not micro. Microaggressions are not micro for the person on the receiving end. And once we understand that, then we have to say, well, what can we do about it and how can we start diminishing these? But at the same time, and in the same breath, I think Heather and I both want to maintain that microaggressions are importantly different from just like outright aggressions and acts of racism or transphobia. And we don't want our account does not hinge on the intention behind the person committing them, because that's just an area that we will never know people's true intentions, and we often don't know our own true intentions. So we don't want intentions to be the linchpin on which, we can determine whether or not this was a microaggression or an outright aggression. And this is why we sort of, again, like want to look at these in context, and we have to look at patterns, and we have to, understand this from the perspective of the person on the receiving end. But we do want to sort of make the case that microaggressions are a thing that are different from outright aggressions. And once we understand the harms, we can understand that there are different harms that result from microaggressions as from, overt racism and homophobia, though there might be some overlap there. But it is a really tricky concept, which is why it's interested us for so long.